so really glad to have Laura here today to talk about when events insist on happening more than once. Great title. So Laura is a senior lecturer in the Department of Health Data Science at the University of Liverpool. She works on the development and validation and implementation of prediction models for recurrent conditions such as epilepsy and asthma. And I'm informed that in certain circles she is referred to as the penguin poo lady because of her outreach work in schools. I will refrain from referring to you in that way, Laura. So without further ado, if you want to take the floor, Laura.
Brilliant. Thank you very much, everybody. And thank you so much for the invitation. It's rare that I get to write a talk from scratch. So it's been a real pleasure being able to write something that kind of brings previous talks perhaps a bit more up to date. So hopefully there's something for everybody this afternoon. I'm very conscious that my title is quite comical, and this talk is not full on methods. There's no formulae, there's no theorems, because for me, you can get that from textbooks, you can get that from papers I reference. This talk is more about where we're up to at the minute and kind of some of the bigger picture stuff. So if people have questions about the nitty gritty, by all means, ask me when we get to the Q&A at the end. Okay. Now, I just need to work out how to progress my slides, which you'd think would be obvious. There we go. Cool. So what I'd like to talk about today is prediction modelings in setting where events don't quite behave as neatly as we might like. Because in most prediction modelling, dare I say, we make a very convenient assumption. We assume that an event happens once, so a patient has a single seizure, or they have a single hospitalisation, or a single relapse. And then from a modelling point of view, we just kind of crack on and we expect events to just stop. And really, that isn't what we see. That's not clinical reality. In many in many settings like asthma, epilepsy, infections even, events insist on happening more than once. People with epilepsy have lots and lots of seizures. People with asthma have lots and lots of exacerbations. And as soon as we allow that to happen, a lot of what we think about model building and evaluating prediction models kind of falls to pieces a bit. It's not, you can go from the single event to a recurrent event and just use the same methodology. And we all know that prediction models are really useful and increasingly are used to support decision making, things like who to treat, when to intervene, how intensively to monitor, and things like that. But the way we build and evaluate models for repeated medical events is still largely inherited from the single event settings. So I want to focus today on what changes when events don't stop at one and how that affects how we evaluate models. But before we get into the nitty-gritty, I want to ask a much more basic question. What are people doing in practice when they build prediction models from recurrent events? There are lots of methods out there for analysing recurrent events. If you look at the main textbooks, you'll see statistical analysis of recurrent events by Cook and Lawless, and you'll see modelling survival data by Thurnau and Grambach. And they're really good textbooks. They've got lots of code, they've got lots of application and lots of examples. And they cover a whole range of different approaches. And things you might see in there might be count-based approaches. So Poisson, for example, negative binomial, or zero-inflated negative binomial. And the zero-inflated is important because in real life, people don't all follow the same trajectory. They don't all have events. Some people in epilepsy, for example, will receive medication and never have another seizure. And so you get a peak at zero of people who have had no further events. So zero-inflated models can be quite useful for clinical practice. There are also a body of models called shared frailty models with options like shared gamma frailty and so on and so forth. And then there are variants on the Cox model, such as the Anderson-Gill model and the Prentice-Williams-Peterson model. Now, as I said, I'm avoiding maths. It's really not my thing. I hate trying to write slides with maths on them, and I hate trying to talk about maths, so I've avoided that. But if you'd like to know more about any of these models, then have a look in those two textbooks that I referenced on the previous slide, or ask me about it later, and I'll be happy to discuss that in more detail. But what we're interested in here is not just how do we model recurrent events, we're really interested in prediction models for recurrent events. So the question becomes kind of where are we up to in practice? And to answer that, a former PhD student of mine, Vicky Watson, carried out a massive systematic review on the literature. The systematic review is published in Diagnostic and Prognostic Research, and it was a beast. I'm going to be honest. We ended up including 301 different prediction models. So it was an absolutely massive review because we were happy to accept any clinical area. We just wanted to know how were people building prediction models with recurrent events. And as you might expect, we found a massive amount of variation. There were different modelling approaches being used, over 10 in fact. The Anderson-Gill, which is the variant on the Cox model that I mentioned before, and frailty models were the most common ones. And the Anderson-Gill was used in about 50% of the included models, frailty in about 40%. But me being a slight cynic, I'm not sure whether they're the most common ones because researchers read other papers and went, oh, they've used an Anderson-Gill. I'm going to use an Anderson-Gill, or whether that's because the researchers felt that the Anderson-Gill or the frailty was the most appropriate model. I'm guessing it was the former there, but obviously I don't have any proof of that whatsoever. But I think sometimes we go, you know what, they did it like that, I'm going to do it like that. And we haven't necessarily thought through whether that is statistically most appropriate. Also, thinking about the systematic review that Vicky did, we need to think about validation. Has anybody done evaluation? Well, a quarter of the studies performed some kind of internal validation. An external was performed in 3 out of 301 studies. So not exactly often. And even in those studies where there was validation, it was literally like looking for a needle in a haystack, trying to find calibration or discrimination. They were rarely mentioned. And if they were, it was really unclear how they'd adapted to the recurrent event prediction model. So this kind of raises this really fundamental question. We're not fitting the same models to our data sets. Okay, Anderson-Gill and frailty are fitted quite often, but it's not apparent whether that's because that's what people do or whether that's the right model. And then even if we are fitting models, we're not very sure as to how to evaluate these models and how to interpret their performance. So frankly, things are a bit of a mess. And this is the situation that I kind of landed upon many years ago when I was a postdoc fellow through the NIHR, and I was like, epilepsy models shouldn't be time to first event. That's not appropriate for epilepsy. What should we be doing? So we saw in that systematic review that methods are varying, that there's really inconsistent validation, and that there's incomplete reporting. So we're a little bit stuck. And I was panicking initially as to kind of like, well, hang on, this is a disaster. What's going to happen? But then I kind of remembered that's what happens in prediction modeling in general. There's a fairly old review up there from Baumeister, and there's a recent review from Winans here. And in both cases, they say that we're not great at doing prediction modeling. And I know that there's lots happening in the world to improve prediction modeling. We now run great training courses, there's reporting guidelines, and we are definitely on the move. But I think it's very easy to go recurrent event prediction models are a disaster. But I think we have to be a bit more mindful that prediction modeling is an evolving world, and recurrent event prediction modeling is evolving more slowly, admittedly, but it is evolving too. So let's try and make a bit of sense of this mess. I'm going to start with a simple example because I find that much easier than equations and formulae. So imagine we've got 2 patients. This is patient A. They've had 1 seizure, and that happened fairly soon after their diagnosis of epilepsy. And I should explain here that to get a diagnosis of epilepsy, you have to have had 2 seizures. So we're saying this person's had 3 seizures. It's just the one after diagnosis was fairly soon after that diagnosis. Then let's imagine that we have a second patient, patient B, and this person's had many seizures, but these happened quite a while after diagnosis. So we can kind of draw a bit of a plot and we can kind of make it look a bit more sensible. So this might be that first seizure. And then you might find that over time you get a pattern like the one you can see on screen. Now, if I was to say who's at higher risk of a future seizure, to me, it's really obvious that patient B is clearly having more seizures and therefore at much higher risk of having a future seizure. But the answer depends entirely on how you define your outcome. Are you interested in risk of any future event? Or are you interested in expected number of events by a particular time point? Or are you perhaps interested in event rate over time? They sound very similar, but they're not the same, and they perhaps need to be treated in different ways. So that ambiguity about the outcome is really at the heart of prediction models for recurrent events. Because if we're not clear about what we're predicting, it becomes really difficult to know what sort of model to fit and how to evaluate that model. So the absolute kind of first rule, I reckon, of fitting recurrent event prediction models is to think so carefully about your outcome. Clinicians I've worked with so far, from liver cancer, from epilepsy, from asthma, from tuberculosis and malaria, are all really different, which is lovely, but really unhelpful too. Some seem interested in the expected number of events by a time point, but others definitely want to know about time to next event, and time to next recurrent event is really, really tricky. So I'm currently favouring those that talk about the expected number of events by a particular time point. And I'll perhaps come back to a little bit about the time to next event in a bit. So let me recap. This is perhaps all familiar stuff to you, but it might be brand new as well. So most prediction modeling approaches assume a single event of interest: treatment failure, relapse, death, something like that. But that usually doesn't reflect the clinical reality that some events insist on happening more than once. So in recurrent event settings, we need to be explicit about what outcome we're predicting. And then we need methods designed specifically for these kind of data. And that brings us to the question of, well, how do we evaluate these models? We all know that we should be considering calibration and discrimination of the prediction model, and that's a minimum. But how do we do that? And it's not actually that trivial. This is the challenge of going, well, we can just use what we do for single event prediction models. Well, actually, we can't really. So let me start with calibration, because that's marginally easier within the recurrent event world. So if you have a single event prediction model, calibration is conceptually fairly easy. You're looking at predicted risk versus observed risk. But with recurrent events, things get a little bit more complicated, and quite quickly, because now there's not just this natural outcome of risk of single event or time to first event. A model might be predicting the probability of at least one event, or it might be predicting the expected number of events, or it might be predicting an underlying event rate. And each of these leads to a slightly different notion of calibration. So we did quite a lot of work on this as to how to evaluate performance. The title should officially be How to Evaluate Calibration and Other Performance Measures, because discrimination is not included as part of that paper. That's my caveat and apology. But this is in diagnostic and prognostic research. And it came from work that I did as part of my NIHR postdoctoral fellowship. Now that postdoctoral fellowship was from 2015 to 2018. You'll notice if you squint really hard at your screen that this wasn't published until 2025. There's definitely something in here about persistence paid off, but this was a really tricky piece of work to get published. It took a lot of toing and froing with reviewers, and we were really pleased to get there in the end, but this was definitely a labour of love. Now, if you've already read this, that's great, and I won't go into too much detail, but in brief, we used an epilepsy data set and an asthma data set to explore different approaches to evaluating calibration to see how it might behave in practice. Now, if you're not familiar with epilepsy and asthma, asthma is a chronic lung condition where people have exacerbations, and clinicians tell us that somebody who's quite poorly with their asthma might have one exacerbation a month. Perhaps slightly more, perhaps slightly less, but a poorly person might have about one a month. Epilepsy is a condition of the brain and it's typified by seizures, but there are 40 plus different seizure types. And so it's a very heterogeneous condition. If you happen to have what we call absent seizures, then somebody who's poorly with absent seizures could have 100 in a day, 300 in a day. So over the course of a year, that's a massive number of seizures to be recording. So we picked epilepsy and asthma because they were kind of high event rate data and sort of middle event rate data. And we kind of went, oh, right, risk. Now, what is that risk of? Well, it could be risk of all sorts of things, as I've already mentioned. It could be risk of a future event or a future number of events, or it could be the event rate, all those different things. So what we needed to do is to simplify things. So what we did is we moved away from thinking about risk and focused on an expected event count in a particular time period. This was deemed relevant by the PPIE groups that we worked with and also some of the clinicians we worked with. So we felt that this was a kind of good starting point. Because once you do that, calibration becomes slightly more straightforward. I say simply, I hate that word, but you're comparing predicted number of events by a time point with the observed number of events by that time point. And that's something that fits in with kind of our notion of calibration already. And that's something we can visualize and quantify. Now, we didn't just want to look at a calibration plot. We wanted to do more than that. So we also looked at some metrics that you may be familiar with. So mean absolute prediction error, MAPE, root mean square prediction error, RMSPE, and also bias. Again, I'm avoiding the maths. I really don't want to kind of, go into the maths. And I'm massively summarizing, but I found this online and I think this is really quite cool as a summary. So it says MAPE tells us typical error. RMSPE tells us about big mistakes and bias tells us about systematic drift. And I kind of like that. That makes sense to me. We're thinking MAPE kind of, have we got, generally over predicting, generally under predicting. RMSPE is telling us about the big errors. And then bias is telling us about a systematic drift. I've realized there's a typo on there. Apologies for that. It's root mean square prediction error. But of course, we can also look at calibration plots to visualize agreement between predicted and observed counts by a fixed time point. So if I just introduce you to the plot you can see on screen, obviously there are 4 different calibration plots. We've got one for negative binomial, one for zero inflated negative binomial, one for Anderson-Gill, and one for the PWP, the Prentice-Williams-Peterson model. And for those who like the nitty-gritty of this is a total time model rather than a gap time model. So we're looking at the total time that the individual has been observed for, not just the time since their last event. And we have along the bottom the observed seizure count by our 2 years, and at the y-axis we've got the predicted seizure count. In an ideal world, all our observations would fall along this diagonal black line of agreement. And you can see that for negative binomial, zero inflated negative binomial, and Anderson-Gill, for this particular clinical example, which was epilepsy, the models are not showing good calibration, but the PWP model is showing good calibration. I can go into lots of details about that, but for me, the clinical example is one thing, but fundamentally this demonstrated to us that we could move from risk to event count, and we could use that as a method of evaluating calibration and therefore distinguishing whether a model is calibrating well or not calibrating well. If I'd have ended up with a plot that looked really bad for all 4 modelling approaches, then I would be perhaps more nervous that approach to evaluating calibration of a recurrent event model wasn't quite so appropriate. And these approaches are kind of familiar. We're just applying them to counts rather than seizure risks or event risks. So I guess rather than asking, is the predicted risk correct? We're just asking, are we getting the right number of events? And that doesn't feel too much of a step from the comfortable, the familiar. But as we all know, calibration does not tell us the full story, and we don't actually get very far towards a full tripod AI assessment if we just look at calibration. So while there has been a bit of work on calibration already, there's still quite a lot of work to be done. So In terms of how we evaluate discrimination, this is completely different and much more conceptually challenging. Discrimination, we're thinking about separation between individuals, and we're thinking about ranking individuals in the right order. And that's not too bad. Ranking makes sense if you move from risk to predicted counts. But the full definition of discrimination becomes much more challenging for recurrent events. So Kim et al. Have thought about an approach here which is based on the concordance methods. And then also there's an approach by somebody I can't pronounce, I'm afraid to say, who has looked at these are Breyer methods. But neither of these have been widely adopted. And they're not currently being used in practice. So we wanted to evaluate why that was the case and see if there was something that we could do. Because as we know, discrimination is absolutely a core part of model evaluation, and we know that we have to report it as part of TradePod II, for example. So how, in practice, can we distinguish between patients at higher and lower risks when events insist on happening more than once? How can we evaluate discrimination for recurrent event prediction models? So let me introduce you here to two of my excellent research assistants. We've got Alexandra Hunt and we've got Thomas Spain. And we've been thinking quite a lot about discrimination. So instead of focusing on time to first event, we're obviously trying to use our notion of predicted and observed cumulative event counts by specific times. And we're thinking about using those to assess how well the model separates individuals in terms of their overall event burden, dare I say. Now, once you can think about that, you can begin to adapt some of the rank-based measures. So C-statistic, Kendall's tau, Summers D, and so on and so forth. But apply them to cumulative event counts rather than single event outcomes. And depending on the event rate, this can absolutely decimate your computer, as Tom will attest to. We got really excited. We spent a lot of time kind of doing paper-based approaches to discrimination for just like 5 patients and then 10 patients. Then we moved into computer code, and it worked quite nicely for 5 patients, and then it worked quite nicely for 10 patients, and then it worked well for our low event rate data and our medium event rate data. But as soon as we gave it an epilepsy data set, it absolutely killed the computer. So Tom managed to solve that by writing in C++ from R, which is quite cool. And he's put that code on the GitHub page that you can see on the screen there. Now you'll notice I've included Tom's email address too, because I definitely don't speak computer code anymore, and I definitely don't talk GitHub. So if you'd like to know some of the nitty gritty about the C++ stuff and any of the way that Tom's written the code, then please do ask him. He will definitely be able to help. Okay, so we've got calibration kind of covered. We can do calibration plots. We've got other performance measures in terms of bias and MAPE and RMSPE, and we can get a measure of discrimination by looking at event count and in the predicted sense and in the observed counts, so that we can still rank individuals and so that we can still look at concordant pairs, discordant pairs, and tied pairs, depending on which approach you want to use for measuring discrimination. Then we had the massive elephant in the room that says, how do we estimate uncertainty? We thought, well, you know what we can do? We can use bootstrapping because that's what's normally done and that makes a sensible approach. But maybe we can't use bootstrapping. Maybe we need to do something else. And that's because with recurrent events, we have multiple observations from the same individuals. Those observations are clearly not independent. But some of the simple bootstrapping approaches implicitly treat observations as if they were independent. So we tried modifying bootstrapping so that it wasn't resampling rows of data, it was resampling individuals with all their different events. But then when you do that, you end up with a huge amount of tied data. And so you then end up underestimating variability. You're not fully accounting for the clustering of events within individuals. We've got multiple individuals that have got exactly the same event times, and it just ended up being an absolute mess. To reiterate that somewhat, this is a beautiful setup of bootstrapping when you have individuals. Okay, very simplified here, 3 individuals. But if this individual A has had 100 events and this individual B has had 300 events, then it all goes a bit wrong and you end up with bootstrap samples that aren't the same size. You end up with then people being duplicated, and the discrimination code means that you end up with multiple tied events, and then it doesn't estimate correctly, and it all just gets to be a really big mess. So to make that even more clear, because we were really stuck on this for some time, we were kind of saying, okay, let's just keep this really simple. Let's say we have 10 patients, and between them, they've had 100 events. If we treat those 100 events as independent observations, we look like we've got a really big amount of information, but we've not. We've just got 10 people. So we have to deal with the patients and their events simultaneously. And that's really problematic when we do bootstrapping. And so we spent a huge amount of time looking basically like this. Perhaps we were all that young when we started, I'm not sure. But we had to think about a different resampling approach that respected the fact that events are clustered within individuals and that we can't keep adding the same person back in, because then we have tied data which isn't appropriately accounted for within the discrimination formula. So we spent probably a year looking at this. And one approach we explored is something called delete D jackknifing. And I'm going to be honest, I had never heard of this before. So apologies if you know of this already, but I'm just going to spend a little minute explaining what we mean by this. It is quite a basic idea. So instead of resampling individuals and putting them back in, we actually leave them out and refit the model or recompute the metric and look at how much the result changes. So rather than asking what happens if I resample individuals or events, we're saying what happens if I remove groups of patients or groups of events. And actually, if we consider that at the person level, we're preserving this within person structure, and we're not so bounded by the need to keep the sample size the same within our resampling, because we're always working with whole individuals and all of their events. So clinically speaking, that feels more comfortable, and statistically speaking, that felt slightly more comfortable too. So going back to my silly example before of 10 patients with 100 events, what we're doing now, instead of putting various combinations of those 10 people back in, we're just removing some of those 10 patients each time and seeing how their events change. And that, we feel, reflects better the true data. But then there's the elephant in the room, the D, delete D. Well, the D refers to how many individuals we leave out each time. So instead of leaving one out at a time, we might leave a group of, say, 10% or 20%. But what should D be? And this was a bit of a rabbit warren we went down to. This isn't completely solved. There isn't clear guidance yet on how many individuals should be removed or what the optimal choice of D should be. We have been relying on the textbook you can see on the screen there, and a particular chapter within that called Bootstrap Methods, another look at the jackknife. And so we, for now, are following the recommendations from the existing literature, but I think realistically we need to do quite a lot more digging into what D should be for these recurrent event models. So we're one step towards a more realistic uncertainty, but definitely not at the final answer yet. Now, I will explain this graph in a minute, but what we've done is we've applied these various discrimination approaches with some alternative uncertainty measures to the real data sets, the epilepsy data sets that I was talking about before, and also the asthma data set. So the red data relates to the epilepsy data, the high event rate data, and the blue data relates to the asthma data. Along the bottom, in incredibly small print, I appreciate, we've got the Anderson-Gill model, we've got the negative binomial model, we've got the Prentice-Williams-Peterson model, and we've got the zero-inflated negative binomial. So the AG and the PWP are not next to one another, and the negative binomial and zero-inflated are not quite next to one another. It's the same layout here, Anderson-Gill, negative binomial, PWP, and the zero-inflated. We also have some shapes going on just to add some complexity for you. So the circles that you can see on the left of each pair, these are looking at the grouped jackknifing, and the triangles are looking at leave one out jackknifing. Okay, so I'll just let you digest that a minute. There are things to notice. There is definite change in the discrimination across the 4 different models. There are definitely, however, some similarities between similar model types, with the exception of this one in both cases, which is the PWP model. So we've also got differences in widths of confidence intervals. Confidence intervals are substantially narrower in asthma than they are in epilepsy. And this is also the case when the group jackknifing is compared to the leave one out jackknifing. So what does all of this tell us? Well, this is saying that when we look at group jackknifing, so delete D jackknifing, we find that models with higher discrimination, so I'm looking particularly at the PWP model here, tend to have narrower confidence intervals than models with poorer discrimination. So these ones down the bottom, similarly up here, the PWP model has much tighter confidence intervals than the other 3 approaches. Also, you tend to notice that the confidence intervals obtained via your standard leave one out jackknife are minuscule, completely unrealistically small. So we know that taking one patient out at a time doesn't lead to a sensible estimate of uncertainty, but leaving 10% out, which is what we've done currently in the circle estimates, is perhaps not too bad. So what do I want you to remember from this? Well, I think for me, we need to be aware that discrimination isn't just about a choice between Summers D, the C statistic, Kendall's tau, etc. It's also strongly influenced by defining your outcome. And it's also important to think about uncertainty. You can't just go, yep, there's my estimate and there's its associated confidence interval. Tom's code has lots of variations on estimating discrimination, and it also has the delete D jackknifing built into it. So if you want to investigate further, you absolutely can. This work is currently under review, so apologies if this is featuring on your to-do list at the minute. Okay, so far I've focused on how we evaluate prediction models for recurrent events. But performance doesn't just happen on its own. It depends heavily on how the model itself is specified. And that kind of leads us to a slightly different question. We're thinking more about what aspects of model choice actually matter in practice. And we've been exploring this through 3 different PhD projects, actually. So I'm going to briefly introduce you to 3 students and explain a bit more about their projects. I'm aware that 2 of the 3 are on the call, so they are definitely going to be best placed to answer questions you have. So first of all, I've introduced you to Vicky before, but Vicky, as a PhD student, has now graduated from her PhD, but is continuing to work with us looking at how do different modelling approaches behave when event rates vary. So Vicky started this as part of a PhD and is continuing this in a kind of revised version of the work currently. And we've gone simple because we thought that simple was a good place to start. So does it matter which modelling approach you use if you've got low event rate data, medium event rate data, or high event rate data? And I've put 3 plots for you here. It would be lovely, I admit, if these were all overlaid on top of one another, but there were too many shapes and colours and things for us to get our head around. But we are trying to think of that at the minute. We've got root mean square prediction error on the left, and we've got MAPE along the bottom. And then we've got 4 different modelling approaches: Anderson-Gill, PWP total time, PWP gap time, and the shared gamma frailty. And at the top, we've got low event rate, we've got medium event rate bottom left, and high event rate bottom right. And we found that absolutely it does make a difference depending on how the model performs, depending on the model that you pick. So this is work that's ongoing about which model do you choose depending on the event rate of the data. And there's definitely a favouring towards the Anderson-Gill or the shared gamma frailty for low event rate, with a preference towards the PWP total time model for the medium and high event rate data. Also, I'd like to introduce you to Jyoti Sehgal. So Jyoti is a PhD student at the University of Cambridge, and she's taking things even more complicated because we go low, medium, and high is nice. Definitely a good starting point. But is it right to assume that a simple Poisson process is correct? Is that the right way of simulating this data and of considering this data? And we perhaps think it's not. So Jyoti is thinking about non-constant rate functions and also event dependence. And so she's thinking about lots of different ways of simulating recurrent events under lots of different conditions to try and see which models work most appropriately for that. Oh, okay. Then we also have Tom Spain, who is the coder that I've mentioned before, and I've shared his GitHub page for all of this. Tom's going one step even further, and he's not happy to just think about the recurrent event, but he's also thinking about how you handle the things that change over time whilst the events are repeating. So he's looking at joint event, recurrent event models. We can't quite work out a good name for these. So if anybody can combine joint models, recurrent events, then that would be brilliant. And he started off by doing a systematic review of prognostic models for joint, longitudinal variables and recurrent events. So that's where we're at the minute. So across all three of these strands, there's a consistent theme. Model performance is clearly really influential in terms of modeling choice, but it's not immediately obvious which models should be chosen. And so we need to think about which models we should be using. We need to think about how we evaluate those performances too. And we need to think ultimately about then how we handle time varying information. So what should we do in practice? I think, first of all, we need to be really explicit about what we're predicting. At least one event, number of events, a rate, because everything follows from that choice. We need to use the right performance metrics to evaluate the models that we've fitted. And we need to avoid relying on a single performance measure, just the same as in single event modeling. And obviously, we need to sanity check against the data. Just summarizing events isn't enough. We need to check that that's clinically plausible. There's still stuff we don't know. We're still working on thinking about how we should handle nonlinear effects within recurrent event models. Splines MFPs are lovely, but there's no existing code currently for fitting these within recurrent events. We don't know about sample size. I dread sample size, but it's one of those things that conceptually is quite easy. But are we talking about a minimal number of people, a minimum number of events per person, a minimum number of events per data set? So we need to think really carefully about that. And we also need to think about decision making. Net benefit's great for single event outcomes. Can we move that into the recurrent event world? What should the decision threshold relate to? I don't know. There's a lot more thought required there. So to conclude, recurrent events are really common in clinical practice, but the tools we're using currently haven't fully caught up in terms of prediction modeling. Concepts like calibration and discrimination still apply, but we do have to redefine them a little bit. And there are papers out there or under review with more details, but there's lots more work that we need to do in this area. Some of that's ongoing thanks to Vicky and Jyoti and to Tom. But in the meantime, when events insist on happening more than once, we have to be much more explicit about what we mean by prediction modeling and how we build and evaluate prediction models for recurrent events. Thank you very much, everybody.
Thank you so much, Laura. You can see a flurry of applause. Well deserved. Yeah, thanks so much for that, Laura. It was a great talk, and it's really interesting to see all the work that you and the team have been doing. Yeah, love your presentation style. The less questions, the better. So yeah, I wonder if anyone in the audience has any questions. You can feel free to raise your hand or use the chat. If you have any questions for Laura about any of those strands, I feel like we've got a real tour de force there of everything you've ever thought about.
Well, I was trying to summarize in 40 minutes kind of where we're up to, what's been done, what still needs to be done, and so on and so forth.
Yeah. Okay. Yeah, we have a question.
Hi, thank you so much for sharing this really exciting talk and on such a complex topic. And applause to you and your team for doing all this legwork. It sounds to me, listening to this, like the underlying hazard function kind of determines quite a lot whether it's a PWP or whether it's a log, etc. So, do you suggest a sort of conceptual framework in approaching this? You kind of alluded to it, like see the actual data, feel how it looked like manually for a few samples. I think that's always a good recommendation. Do you have any sort of recommendation for conceptual framework before diving deep down into the collective auto fitting and choices? That's my question. Thank you.
Yeah, so that's something we really like to be able to do. And ultimately, we're hoping that Vicky and Jotty's work combined will lead to that really nice, if you have this data, do this. If you have this, we're not there yet. I'm going to be honest. The more we do in recurrent events, the more we realize we don't know. So we had to get calibration and discrimination sorted first, because otherwise you fit all these models and go, that's nice, but you can't separate which ones are working well and which ones aren't. As I said, in terms of Vicky's basic simulations, that's really unfair to Vicky, but in terms of the step one simulation, we have found that Anderson-Gill and shared gamma frailty seem to be a good starting point for low event rate data. And PWP seems to be most appropriate for medium and high event rate data. But those thresholds for medium and low and high are really, really basic, and we need to do much more on that. But yeah, if you've got something that's happening probably 12 times or less in 1 year, then probably Anderson-Gill's a good starting point. If it's more than that, probably PWP is a good starting point.
Sorry, for one follow-up question. Thank you so much again. What are your thoughts about sort of a more for framing it within a Bayesian or Markov process? Because that kind of capture Markov includes the past events in that point, and Bayesian also like really just your posterior. So I wonder whether you thought about that or what your challenges are. Thank you.
Yes, so it's definitely something we're thinking about. Jotty is definitely more of the expert on that than I am, but the challenge we're having is the writing it down. I don't mean literally writing it down, but in the conditions that Jotty's looking at, so acute myeloid leukemia, and in epilepsy that we're looking at, no two people have the same pathway. So to try and map that out in some sort of multi-state model or in a Markov framework, we're just struggling to kind of make it work. I think it has potential in simple clinical situations, but for real life recurrent events, we're not sure that it's going to be a workable solution.
Thank you so much.
Thank you. Is there anybody else? No? I'll jump in. Laura, you might not appreciate this, but I'm interested in the time to next recurrent event. I'm wondering whether that is, you obviously work with a lot of clinicians and patients, and you said you're on the route of expected number of events now. Is that because you can handle that better, or are people, what do people want? What's useful to people? Is it time to next event, or is it?
Yeah, and this is the problem. What do people want? I've been involved in an epilepsy project as part of the Academy of Medical Sciences Fellowship, and we've done a lot of PPI work with clinicians, with patients, and with relatives of patients. And they all want different stuff. And I completely get that, because if you're in a clinical situation whereby you're not having seizures very often, time to next event might be very meaningful. If you're, however, having 100 seizures a day, time to next event could be 20 minutes, and that is not helpful to you whatsoever. Similarly, for clinicians, time to next event is great if you want to plan a clinical appointment and can intervene. So time to next asthma exacerbation is something that you can perhaps fix by giving preventative medicine. Time to next epilepsy seizure is completely useless because we can't currently give any medicine to prevent a seizure. We can try and reduce the account over time, but knowing exactly when it's going to happen is just terrifying for the individual. So whilst we think that we might be in a position to be able to estimate time to next event, we need to be really comfortable that that's clinically appropriate before we start sharing that information, because once that methodology is available, We don't want to be in a situation of causing adverse mental health concerns or actually making the situation worse. So it's something that we're thinking of, but thinking of very slowly and very carefully.
Yeah, it sounds very, it's complicated. And sorry, so before I ask the next question, then on that point, you were saying about a case where you don't care about time too because you have so many that it's irrelevant. So then let's say you care about expected number of events. What's the threshold you put on that? Or again, do people not really care? Is it one? And that's what they care about.
And that's the thing. And so that's why in epilepsy, we've been okay for a while by looking at time to first event or time to treatment failure, because there is lots of meaning in that.
Yeah.
But it's the middle that we're concerned about. You know, not having many events is fine, and that's okay because treatment perhaps is working for them. Having millions of events is not fine clinically, but is fine statistically because we know they're having lots. What we really want to be able to do is to account for those who are somewhere in the middle and are having enough of a number for it to be a burden, but not enough of a number that this is their sole purpose in life. And so in those situations, time to next event could be quite useful. With an epilepsy, we spend a lot of time concerned about 12 months without seizures, because in the UK, you can regain your Group 1 driving licence if you've stopped driving or if you haven't had seizures for a year. So in that instance, am I going to be seizure free for at least 12 months would be absolutely really helpful, because you could give that evidence to the DVLA and say, please, can I have my driving license back? I'm not expected to have a seizure for another 20 months. But then you have to have the spread on that. And then do you base that on the lower bound? Do you base it on the upper bound? It's a minefield in itself. So there is worth, but there's lots of complexity too.
Yeah. Okay. Does anybody else have any questions they want to ask Laura?
This is when everybody decides they don't want to do anything with recurrent events anymore.
Yeah, there was a lot of complicated questions that you raised. I was going to ask you what was more. It sounded like it was more complicated with the time to next event, but maybe we can elaborate on that another time.
Yeah, it's the complexity of that is around your reliability. You can guess based on what's happened previously, the time to next event. But if you want anything more robust than, well, it was 10 days last time, let's assume it's 10 days going forward, then you have to think about the functional form, which is where Jotty's work's coming in.
Okay. Thank you. So yeah, we don't have any questions from the audience. Then yeah, I'll wrap up. So yeah, just to say to everyone, thanks for coming and thanks for joining us today. Just a plug for the next seminar. So the next seminar, we are welcoming Professor Penny Watting, who will speak about Quadus 3. So this is an update to a version of widely used Quadus 2 tool for quality assessment for diagnostic test accuracy studies. So her seminar, if you're interested, will be 1 to 2 p.m. again on the 12th of May. And if you'd like to keep up to date with the seminars and the upcoming seminars in this series, then please drop us an email or a quick message in the chat there, and we can add you to our mailing list. Okay, so I think if we could all just thank Laura again for such a great talk. Thank you, Laura.
Thank you for inviting me.
Shame